Welcome to this second lecture on glaucoma. We are going to cover primary open-angle glaucoma, its definition, risk factors, theories, what's cupping, visual field effects, medical therapy, laser therapy, and surgical therapy, which is called trabeculectomy. So I'm just going to revise the definition of glaucoma. It's a progressive, so you should come out with the correct answer, and I'll show you the correct answer again. It's a progressive optic neuropathy characterized by cupping of the optic disc and characteristic visual field effects with intraocular pressure as a risk factor. Most of the students, when I ask them the definition, will say that it is a disease which is characterized by raised in intraocular pressure. So we have to be very clear that the definition has been revised and now it is a disease with intraocular pressure as a risk factor, because the intraocular pressure might be normal, which is called a normal tension glaucoma, or it might be high, which is called glaucoma, and sometimes it is high without any loss of visual field effect and cupping of the optic disc are not present, and that case with raised intraocular pressure is called ocular hypertension. So for primary open-angle glaucoma, the things which come positive are the angle should be open and the intraocular pressure should be higher than 21 millimeters of mercury. So now we're talking about a patient with open-angle glaucoma. So in those patients, the pressure is going to be higher than, so the pressure is going to be raised. So it's normal tension glaucoma where the pressure is going to be normal. So when you go in for a broader definition of glaucoma, then it is IOP as a risk factor, but when you come on to the definition of primary open-angle glaucoma or the characteristics of open-angle glaucoma, then the intraocular pressure has to be high. The third thing is glaucomatous optic disc damage or cupping of the optic disc, and the last one is the visual field defects. Here you can see a patient having superior arcuate scotoma, which we'll explain in later slides. The next MCQ can be the glaucoma is the most commonly seen at which one of the following, either the white race, African race, Hispanics, or Caucasian. So the answer is African race. Glaucoma screening should be done at which age? The answer is out of this is at 40 and above. Can the family members of glaucoma patient have glaucoma? So if a patient comes in with glaucoma, will you ask him to bring his family members for glaucoma screening? The answer is yes. So what are the risk factors? We've already discussed. Most cases present after the age of 40 years. The race most commonly is African race, who have more earlier onset and more severe disease. The inheritance is low level of IOP, outflow facility, and disc size are inherited, and risk is increased by twofold if the parent has open-angle glaucoma and is increased by fourfold if the sibling has primary open-angle glaucoma. And then myopia is another risk factor. So there are 4 risk factors which include age, race, inheritance, and myopia. So what are the different theories of glaucoma? How do you actually get that optic disc cupping? That optic disc cupping can happen because mechanically the optic nerve is being pressed by the intraocular pressure is pressing on that optic nerve and causing glaucoma. Or the other thing which is happening is you're having capillary occlusion of the nerve fiber layer causing ischemia of the nerve fibers, thereby causing interference with exoplasmic flow and loss of the nerve fiber layer, leading to cupping of the optic disc. Then we come on to what type of excavation can we get in patients with glaucoma. Usually it is concentric excavation. So this is a patient who had a picture taken in 1984, and then 1994, 10 years down the line. Here you can see the cup is of this size. So if I say if this is about 0.7 and it is increased to zero point 0.8 in this patient. So the cupping has increased. So you want to see where the bending of blood vessel is happening. So here the blood vessels are bending over here, and over here they're bending slightly further away. So in this diffuse loss of nerve fibers. Excavation enlarges concentrically. So if it is this size, it is going to grow like this. So it's going to concentrically enlarge. Initially, it may be difficult from large physiological cup and compare with the previous record. Physiological cup is an entity which we need to be clear, which I'll go through which I went through last time as well, because most of the patients will have cup to disc ratio between 0.3, but some people with normal eye might have a cupping which is more. So that type of cupping is called physiological cupping, and that you have to find out by doing visual field test or OCT scan of the optic nerve to find out if there is no damage. So the cupping can be localized. So it can be a focal cupping. So if we see a vertically enlarged cup, so the cupping is more in this area. Sometimes there's only a notch, so the rim is not available superiorly. But compared to this, you have a concentric cupping over here. So the disc as whole is enlarged. Here you can see the cup is enlarged vertically, but horizontally it's not enlarged. The reason is because of focal nerve fiber layer loss, which we talked about, is the ISNT rule, in which you know that the nerve fibers tend to get damaged more commonly. The most commonly it's inferiorly, then you have the superior damage. While in diffuse loss, there is excavation and large concentric cupping, and nasal displacement of the central blood vessels occur in patients with glaucoma. So here you can see that. And what is happening in patients with glaucoma, you can see you're having cupping of the optic disc, and that can be seen as loss of retinal nerve fibers. Here you can see slit-like defects on the retinal nerve fiber layer. This is the normal layer, this is the normal, and these are the slit-like fiber loss which you can see on red-free photographs. So this is wedge shaped defect, and this is total atrophy. Here you can see small striations present in the retinal nerve fiber layer. So here those striations are absent. So those are the retinal nerve fiber layers which you can see on a red-free picture or on an ophthalmoscope red-free examination. Here you can see a patient with end-stage glaucoma. So what is very unusual in this picture is what you see is the optic disc looks pale in color, it looks more whitish in color. And here you can see the turning point of the blood vessels has gone to the periphery. So this patient has got about total optic disc excavation. The cup disc ratio has gone up to 1.0. Here you can see the vessels are bending right at the periphery. And atrophy of all the retinal nerve fiber. There's no striations visible in this patient, and blood vessels appear dark and sharply defined. So that's a patient with end-stage glaucoma. So you need to identify whenever you're seeing with a direct ophthalmoscope if there's cupping or there's end-stage cupping. This patient typically might have a very limited visual field, or he might be blind. So that's what this is going to tell you. And now we're going to see some pictures which shows progression of glaucomatous cupping. So here you can see a patient with a normal cup to disc ratio of 0.2. In this one you see a concentric enlargement of cup disc ratio of up to 0.5. So this is the pallor which you see in the center compared to this optic disc. So this area is 0.5 of this whole disc. Here you can see inferior expansion. So there's focal area of expansion of the cupping, and then there's superior expansion with retinal nerve fiber layer loss. So here you can see there's a focal inferior, and then this focal inferior has also evolved into focal superior. So you got a focal superior and inferior defect. And here you can see the lamina of the lamina cribrosa which are coming in as the cupping. This is called the laminar dot sign. And here you can see as the cupping is starting happening, there's nasal shifting of the blood vessels on both sides. And then here you can see advanced cupping with nasal displacement of blood vessels. Here you can here the blood vessels are going into the excavated part, and then they're climbing in and then climbing out. That is the reason why you're not seeing the blood vessel. And then there is total cupping with loss of all retinal nerve fiber layer, and these slit like defects have become horizontal in this patient. Initially they were rounded, but when they are stretched, they tend to become horizontal. So this is a typical advanced end stage glaucoma patient. So blind spot in glaucoma is seen where on visual field effects. This is an MCQ. So you can answer, think about it, and the answer is it's 15 degrees temporal because your optic nerves are present on the nasal side near to your nose. So that is why the optic blind spot is going to be present in the visual field. It is going to be seen on the temporal side in 15 degrees area. So typically, here you can see just by looking at the visual field, you can tell which eye this patient has. Normally, I'd ask you to draw a visual field, and when you draw a visual field, you actually draw your own visual field as if you are looking, and that is the normal notation of writing a visual field. So here you can see if this was my visual field, the blind spot is present on the temporal side. This should be the left eye. So this is the left eye, and this is the same small arcuate scotoma with total tend to elongate along this 15 degree to 20 degree area that is typically called a Jerem's area or a Jerem's scotoma. Here you can see these letters written 12E, 14E, 54E. So these are actually what we call isopters. So this reddish area represents an area where a typical spot of light will be presented and the patient will be able to see. So 1, 2E will be a very small dot of light, 14E will be a bigger dot of light, and 54E will be an even bigger dot of light. So in the central retina where the sensitivity is very high, you will can see very small dots of light with very dim intensity. So this 2E tells you that it is small and it is very dim as well. As you go in the periphery into the rod area, that capability tends to get less, and that's why you will see less of that in these patients. So this is another isolated paracentral scotoma, but it is different from this, that you are getting a peripheral loss which is called a Roney's nasal step. So this is going to be a Roney's nasal step in addition to you've got your Jerem's scotoma, which is present in the pericentral region. All glaucomatous visual field defects are pericentral, so they'll be around the center. If somebody has got a blind spot and he's got a visual field defect involving the macular area, so that is going to be called a centrocecal scotoma, and that is typically seen in patients with optic neuritis or disease or inflammation of the optic nerve. Then we go forward. The first type of glaucomatous visual field defect was Jerem's scotoma or scotomas present in the Jerem's area. So what is a scotoma? Scotoma is an area where you cannot see in the whole of the visual field. So it can be said as a non-seeing area in the sea of vision. So here you can see when the disease enlarges. So typically you can see this is the same patient. So this is the left eye. So it is enlarging over the central area. So this is, and it is forming an arcuate pattern. So this is called a superior arcuate scotoma. And along with that, you also see a Royne's nasal step in this area. And this is a temporal wedge. So those are the three typical type of visual field defects you see. Superior arcuate scotoma, a nasal Royne's nasal step, and a temporal wedge. So this patient, if you look at this optic disc, all the damage or all the focal notching is going to be present in the inferior part of the optic nerve compared to the, so as the inferior optic nerve is damaged, it is reflected in the superior visual field effects. And when you go and with enlarging or advancing disease, what you'll get is this nasal step tends to creep inwards and it joins with the area of the nasal step, and that produces this peripheral breakthrough, and the appearance of fresh arcuate scotoma can happen inferiorly in this patient. So here you got a patient with left superior arcuate scotoma producing a nasal breakthrough along with a temporal wedge. And then we come on to further advanced visual field effects and development when you get two arcuate scotomas. They join together, they produce a ring scotoma. So this patient has a ring scotoma with superior nasal step breakthrough and a superior temporal wedge. And when there's very advanced glaucoma, as we saw a patient with a cup disc ratio of 1, so he just has only temporal crescent remaining. So this is the only temporal crescent which is remaining, and this is what you see in this patient. So this patient, actually, when you ask him to see letters in front of you, he'll actually tend to move his head slightly to the side and look with his temporal field. That is very important to see in these patients because that is the only time when they lose their central vision. This patient actually will have tunnel vision. Tunnel vision, you can mimic yourself, like if you put your hands like this and keep looking through this area, whatever you see is this is what a patient with advanced glaucoma will see. So if this type of patient is going to cross a road, what type of hazard will he have? He won't be able to see the cars coming in until they're right in front of them, and at that time he might not have time to make evasive action and he can be involved in an accident. So we've gone through the basic features of glaucoma. Now, what type of drugs can you use to treat glaucoma? So there are a bunch of drugs. So there are 5 major classes. So the oldest class is the beta blocker. So these are drugs which are going to act on the ciliary body and reduce the production of aqueous in this area. Then you've got sympathomimetics, which we have alpha agonist, which brimonidine is one of the drugs that will cause reduction in production of aqueous humor, which is produced in the pars plicata of the ciliary body. Then we've got myotics. What will the myotics do? The myotics will cause the pupil to constrict, and that constriction will cause opening of the angle. Then we've got prostaglandin analogs, and what do they do? Prostaglandin will, there's another small channel which is called a uveoscleral outflow. So they increase the outflow. There's an area where the ciliary body can be seen in the angle. That is the area which absorbs the fluid and takes it into the, this is the area, this is the sclera, and this is the uvea. So there's a space in between this. So the fluid goes and trickles into this space. So that increases that by modification of certain angle structures. And the last one is carbonic anhydrase inhibitors, which can be given in a topical form or a systemic form. And what they're going to do is reduce the production of aqueous humor. Carbonic anhydrase, acetazolamide is the major oral drug which you use in these patients that typically acts on the sodium potassium ATPase pump present in the ciliary body, and that reduces its function and causes decreased production. Topical carbonic anhydrase inhibitors produce an effect, but they are not as effective as acetazolamide. And now when you say acetazolamide, I think you've recently done your pharmacology, so you'll be more abreast with acetazolamide. Acetazolamide is a drug, when you give it orally, it comes in 250 milligram tablets, It also comes in an injection. The injection is not available here. But the tablets, when you eat those tablets, you tell the patient that you can get numbness and tingling in your fingers. You can get excessive diarrhea with those patients. You can get excessive fatigue. So that is something, and if they are sensitive to sulfur drugs, they can actually get Steven Johnson syndrome. So you have to ask the patient a history of the any drug allergy. So just let's go to the beta blockers. So the drugs available are betaxolol. Either they can be cardioselective. So timolol is a drug which is non-selective, while betaxolol is a drug which is selective. Because it is important, if you give a beta blocker to a patient who's got asthma, he will get shortness of breath, and if he's on the last reserves of his oxygen, he can actually die because of that. So we have to be very careful. And it's also be very careful whenever you give a beta blocker, always check the pulse of the patient or ask him if he's got any heart problem, because it will aggravate bradycardia. Sympathomimetic, which include brimonidine, they tend to cause excessive sleepiness in patients who are older. Miotic drugs like pilocarpine are not typically used for open angle glaucoma. They are usually reserved for angle closure glaucoma. But when you use pilocarpine in very young patients, they tend to get severe headaches because of spasm of the ciliary muscle. Prostaglandin analogs are typically analogs of prostaglandin, so they tend to be irritant and they tend to have redness of eyes, or allergies are very common. The good thing about prostaglandin analog is the only drug which you can use once a day and which is an action of 24 hours is prostaglandin analogs. Beta blockers and sympathomimetics and topical carbonic anhydrase need to be used twice a day or at 12 hourly interval, while miotics like pilocarpine needs to be used 3 times a day. The next we come to the treatment modality. As we talk, number one is medication. Patients usually come and ask them, isn't there a surgical treatment for glaucoma so that I don't have to do anything? We need to put drops in. I can just have surgery done and that's it. Well, I tell them that the glaucoma surgery is slightly unpredictable in that when you're producing an outflow, sometimes you get overflowing and you can get low pressures, and sometimes patients having glaucoma surgery can develop cataracts later on, and sometimes the surgery does not work as effectively because your main mechanism is hampered by scarring. So I'll go through in the next slide. The next step which you can do is laser trabeculectomy, or you can do applications of 50 to 100 burns in junction of pigmented and non-pigmented, and you focus with an argon laser, and nowadays you've got a selective laser trabeculoplasty which actually causes the pores in the trabecular meshworks to increase in size so that the outflow increases in these patients. Or they can be used in patients with primary therapy non-compliant patients who do not want to use drugs and they say they want to just have some treatment. So it's safer than having intervention surgery like trabeculectomy. And the last treatment, or one of the last end of the line treatment, is trabeculectomy. In trabeculectomy, you have failed medical therapy and laser trabeculoplasty. Lack of suitability for trabeculoplasty because of poor compliance or inability to adequately visualize the trabeculum, or as a primary therapy in advanced disease. So here you can see what you want to do in trabeculectomy is you cut a hole in the conjunctiva slightly away from the limbus, and you undermine the conjunctiva and you lift the conjunctiva. After that, you make a trapdoor or a rectangular 3-sided opening in the sclera, and you lift the flap, and beneath that you make a small window into the anterior chamber at the level of the trabecular meshwork. And with that, once you've done that, this is the area, the inner window you create. And in the area of the inner window, you excise the iris so that it does not plug your opening at that time, and it also prevents pupil block glaucoma. So then you put that scleral flap back in place. Here the black area what you see is the iridectomy, which is typically a feature of glaucoma surgery. And the aqueous is going to flow from the eye beneath the scleral flap through that window which we have created. It is going to flow through this window and is going to come out from this side, from this side, and from this side. And this is going to basically, it is a shunt from the anterior chamber into the subconjunctival or the subtenon space. But the main response of any injury to the body, if you cut a hole in anywhere in the body, is to close that hole. So that is the major factor which causes failure of trabeculectomy. Fibrosis causes sticking of the conjunctival and the tenon tissue to this trapdoor and closure of the trabeculectomy. So in order to prevent that, we use antimitotic drugs which include mitomycin for these patients. So that will reduce the formation or failure of the bleb in these patients. The filtration blebs typically look like this. So if you get a short case, if somebody's, always look for peripheral iridectomy in patient. If you see the pupil black area in the pupil, if you see a triangular area or an oval area in the periphery, that means somebody's had an iridectomy. The iridectomy can be an isolated thing, or it can be associated with a small bleb, or it looks like a blister because it's typically fluid draining into this subconjunctival thing. The blebs can be of different type. They can be thin, they can be flat, they can be engorged with blood vessels, or they can be encapsulated. So you have to look out for this, and this is typically what you see in patients with glaucoma. So if somebody's got failed trabeculectomy, you always do a massage of the eye. You can do laser suture lysis, which is an advanced treatment for that. Topical steroids are things which are going to reduce the inflammation. You can inject antimitotic drugs such as 5-fluorouracil to prevent. You can do reoperation. And the other treatment now available is to put a valve in the eye. So a valve is a tube or a shunt which is going to drain aqueous from inside the eye to the outer area, but in a more controlled manner. So with that, I'll finish this lecture. I'll show you a bit of the valve in the next lecture. Until then, go through your lecture. If you have any questions, you can post it on WhatsApp, and we'll see you next week. Thank you.